Hi friends, I'm Dr. Jeev Ram. Today I will discuss about amenorrhea. Amenorrhea is the absence or abnormal cessation of the menses. It can be of physiological amenorrhea, pathological amenorrhea. Classification of amenorrhea: physiological, pre-puberty, pregnancy-related, menopause. Pathological: primary amenorrhea, secondary amenorrhea. Pathological amenorrhea: a patient is diagnosed with primary amenorrhea if she has not reached menarche by age 16 with normal secondary sexual characteristics. Secondary amenorrhea: if established menses have ceased for longer than 6 months without any physiological reasons. Etiology of amenorrhea: hypothalamic causes, hypothalamic hypogonadism, weight-related amenorrhea, anorexia nervosa. Pituitary causes: pituitary adenoma, Sheehan's syndrome. Endocrine causes: hypothyroidism. Ovarian causes: gonadal dysgenesis, gonadal failure, polycystic ovarian syndrome. Outflow tract axis causes: congenital absence of uterus and vagina, vaginal atresia, imperforate hymen, Asherman syndrome. Etiology of amenorrhea: primary gonadal failure 43%, congenital absence of uterus and vagina 15%, constitutional delay 14%, secondary chronic and ovulation 39%, hypothyroidism, hyperprolactinemia 20%, weight loss anorexia 16%. Primary amenorrhea: primary amenorrhea is the failure to start menstruation by age of 16 in a girl with normal secondary sexual characteristics, or by the age of 14 where there is a failure to develop secondary sexual characteristics. Etiology of primary amenorrhea: chromosome mutation, androgen insensitivity, testicular feminization. Hypothalamus pituitary causes: hypothalamic failure, Coleman's syndrome. Ovarian causes: Turner syndrome, gonadal dysgenesis. Outflow tract causes: absence of uterus, absence of vagina, imperforate hymen. Outflow tract disorders: imperforate hymen. Imperforate hymen represents one form of failure of complete canalization of the vagina. Most frequent obstructive anomaly of the female genital tract. Presentation: primary amenorrhea associated with cyclical abdominal pain, abdominal swelling and urinary retention. Signs: bluish bulging membrane at the introitus. Gonadal dysgenesis, Turner syndrome. Chromosomal abnormalities associated with streak ovarian tissue and primary amenorrhea. Presentation: primary amenorrhea associated with features of Turner syndrome, short stature, webbed neck, increased carrying angle at the elbow and sexual infantilism. Androgen insensitivity, testicular feminization, a syndrome found in patients with XY chromosome but resistant to androgens. Has male karyotype, 45XY with female appearance. Presentation: female appearance with normal breast development and external genitalia. Primary amenorrhea: absent uterus, gonad testes. Hypothalamic failure, Coleman's syndrome, congenital disorder characterized by hypogonadotropic hypogonadism. Unichoidal features: anosmia or hyposmia. Primary amenorrhea caused by defect in synthesis and or release of gonadorelin, LH releasing hormone. Secondary amenorrhea: secondary amenorrhea is the absence of menstrual periods for 6 months in a woman who had previously been regular, or for 12 months in a woman who had irregular periods without any physiological reasons. Secondary amenorrhea: physiological. The most common cause of secondary amenorrhea in reproductive age women is pregnancy, and this should always be excluded by physical exam and laboratory testing for the pregnancy hormone HCG. Etiology of secondary amenorrhea, polycystic ovarian syndrome. Polycystic ovarian syndrome accounts for 90% of cases of oligoamenorrhea, also known as Easton-Leventhal syndrome. The etiology is probably related to insulin resistance with the failure of normal follicular development and ovulation. The classical picture: amenorrhea, obese, subinfertility, and hirsutism. Hypothalamic causes. Hypothalamic dysfunction is a common cause, 30%. It is more often seen as a result of stress, weight loss, and eating disorders. It may be due to tumor, infarction, thrombosis, or inflammation. Pituitary causes. Pituitary failure. It is usually the acquired type as the result of trauma, treatment of pituitary tumor, or infarction after massive blood loss. Sheehan syndrome, pituitary tumor, hyperprolactinemia, which cause secondary amenorrhea. Endocrine causes. Thyroid disorder and Cushing's disease interfere with the normal functioning of the hypothalamic pituitary ovarian axis. Present with amenorrhea, high level of thyroxine inhibit FSH release. Androgen secreting tumors of the ovaries cause secondary amenorrhea. Anatomical causes, usually due to previous surgery. Commonest example: hysterectomy, endometrial ablation, Asherman syndrome, damage to the endometrium with adhesion formation, stenosis of the cervix following cone biopsy. Premature ovarian failure. Premature ovarian failure occurs in about 1% before the age of 40. Premature ovarian failure may be due to chemotherapy and radiotherapy, autoimmune disease following viral infection, following surgery for conditions such as endometriosis. Drugs causing hyperprolactinemia. Hyperprolactinemia accounts for 20% of cases of amenorrhea. Prolactin inhibits gonadotropin releasing hormone release from the hypothalamus. Drugs that may cause hyperprolactinemia: phenothiazines, methyl-dopa, cimetidine, butyrofenones, antihistamines. The assessment of amenorrhea: history, examination, and investigations. Assessment: the most common cause of secondary amenorrhea in reproductive age women is pregnancy, and this should always be excluded by physical examination and laboratory testing for the pregnancy hormone HCG. History: a good history can reveal the etiologic diagnosis in up to 85% of cases of amenorrhea. History asks about menstrual cycle and age of menarche and previous menstrual history, previous pregnancies, severe postpartum hemorrhage, Sheehan syndrome, weight change, a large amount of weight loss, anorexia nervosa, hot flashes, decreased libido, premature menopause, certain medications, contraception, associated symptoms, Cushing disease, hypothyroidism, previous gynecological surgery, chronic illness. Examination: check for body mass index, BMI, weight loss related amenorrhea, blood pressure, elevated in Cushing and polycystic ovarian syndrome, androgen excess, hirsutism, polycystic ovarian syndrome, virilization, tumor, secondary sexual characteristic, features of Turner syndrome. Breast examination may reveal galactorrhea, abdominal, hematomera and pelvic masses, ovarian tumor, inspection of genitalia, imperforate hymen, cervical stenosis, vaginal examination, blind vagina, vaginal atresia, absence of uterus. Clinical assessment investigations: if the history and physical examination are suggestive of a certain etiology. The workup can sometimes be more directed. Some patients will not demonstrate any obvious etiology for their amenorrhea on history and physical examination. These patients can be worked up in a logical manner using a stepwise approach. Investigating primary amenorrhea. Blood tests, ultrasound, CT scan of pituitary, karyotyping, laparoscopy. Investigating primary amenorrhea, site of disorder, hypothalamus, diagnosis hypothalamic hypogonadism, investigations, FSH, LH, and estradiol low, site of disorder, pituitary, diagnosis pituitary adenoma, investigations, prolactin high, FSH, LH, and estradiol low, site of disorder, ovary, diagnosis, gonadal dysgenesis, Turner syndrome, investigations, FSH and LH high, estradiol low, karyotype 45XO, Mullerian tract, absent uterus, testicular feminization, PCT negative, karyotyping 46XY, genital tract, imperforate hymen, FSH, LH, estradiol normal, PCT negative, examination imperforate hymen. Investigating secondary amenorrhea. The most common cause of secondary amenorrhea in reproductive age women is pregnancy, and this should always be excluded by physical examination and laboratory testing for the pregnancy hormone HCG. Investigating secondary amenorrhea. Once pregnancy has been excluded, progesterone challenge test, TSH thyroid stimulating hormone, FSH, LH, prolactin level. This chart shows investigating secondary amenorrhea. Hypothalamic pituitary failure. Patients who do not bleed after the progestin challenge but do bleed after estrogen, progestin, and have normal or low FSH and LH levels. Investigating secondary amenorrhea. Site of disorder, hypothalamus, diagnosis, hypothalamic failure, weight-related amenorrhea, investigations, FSH, LH, and estradiol low, pituitary adenoma, investigations, prolactin high, FSH, LH, and estradiol low, Sheehan syndrome, FSH, LH, and estrogen low, site of disorder, endocrine, diagnosis, hypothyroidism, investigations, TSH raised, T4 low or normal, site of disorder, ovary, diagnosis, premature menopause, investigations, FSH, LH high, estrogen low, polycystic ovarian syndrome, investigations, FSH normal, LH high, site of disorder, Mullerian tract, diagnosis, Asherman's syndrome, investigations, PCT negative, HSG, hysteroscopy. Treatment of amenorrhea. The need for treatment depends on underlying cause, need for regular periods, trying to conceive fertility, need for contraception. Treatment of underlying causes: pituitary tumor, bromocryptin, surgery, androgen producing tumor of ovary, surgery, testicular feminization, remove gonads plus hormone replacement therapy, Turner syndrome, hormone replacement therapy, imperforate hymen, surgical incision, thyroid disease, appropriate medical treatment, eating disorders, refer to psychiatrist, polycystic ovarian syndrome, appropriate treatment, Asherman's syndrome, breaking down adhesion, place insert intrauterine contraceptive device. Trying to conceive. The prognosis for women with confirmed ovarian failure is poor. And ovulation responds well with ovulation induction treatment. Polycystic ovarian syndrome. Ovulation may resume with weight reduction, fertility drugs, use of gonadotropins or ovarian drilling, hyperprolactinemia, respond to treatment with dopamine agonist, hypothalamic dysfunction, maintenance of normal weight and change of lifestyle, Asherman syndrome, breaking down ADN plus insert intrauterine contraceptive device. Treatment of amenorrhea, want regular period, the use of combined oral contraceptive, hormone replacement therapy, need contraception, confirmed ovarian failure will not require contraception, women requiring contraception, oral contraceptives are method of choice.